Our guest for the next 1 hour is the boss of the Syndemic Diseases Control Program. Hey, this one, we talked about it the last time, and I was like, eh. So the National Syndemic Diseases Control Council, the CEO, Dr. Ruth Laibon Masha, is our guest. Dr. Good morning.
Good morning.
How are you?
I'm fine, thank you.
Very good. Good to have you here. Dr. The last time you were here, we were talking about the work that the National Syndemic Diseases Control Council does. And now, just recently, of course, the 1st of December, the world commemorates World AIDS Day. And there's a lot of information that then comes out after that. And this time, the last time, it was just after the Safari Rally, and there was this whole conversation about people going to Naivasha and sharing. They're sharing things. They're sharing PrEPs. They're sharing PEP. They're sharing ARVs. They're sharing morning after pills. They just consumption like this and the other, you know. Mm-hmm. Now there's a whole issue about PrEP and PEP. We'll talk about that. But City will first give you the day's proverb. And then, of course, you know what you need to do. Listen to the man, internalize the proverb, and then tell us what the proverb says to you. Where are we this week?
We are in the People's Republic of Mozambique. Mm. Not democratic, not just republic, but the People's Republic of Mozambique. Msumbiji, in other words. Mm-hmm. The grasshopper that was eaten by the hornbill must have been deaf.
Mm-hmm. Mm. Okay, so the grasshopper that was eaten by the hornbill must be deaf. Mm. It means that the hornbill makes some form of noise or buzz, and the grasshopper is one of the insects we know really has instincts to move and leave a space of danger very fast. So if a grasshopper does not hear the noise, that means, of course, it could be deaf, and that comes back to the human beings. Information is power. But if you can get information and you don't act, it's like someone has made noise, and really noise that can save your life, or has tried to give information that could help you move from point A to point B, but you fail to move because you don't take any action.
Connect that with the topic that we have today.
So today we are talking about HIV, and I want to say that HIV is a virus. And that's one of the things that you must not forget. And it's also not just a virus. It's what we call a retrovirus. It's a virus that has the ability to change itself faster than any other virus you've seen in our lifetime. That's number one. Number two, it actually just two things does. It's a transmission and acquisition. One person must have it to give to another person. Number three, it's in human beings. It's not been found to be anywhere else. So it's a human immunodeficiency virus. Once it comes out of the human being, it ceases to live. And then number four is that it's here in Kenya. 1.4 million living with HIV, meaning that we are a country where if, for example, the ways of getting the virus is through sexual transmission, you're likely to get in contact with a person living with HIV because there are 1.4 million. They are everywhere. There's no place in this country where there's no one living with HIV. You can't say there's zero person. And the other way is transmission through mother to child. And now we're also insisting that male partners transmitting the virus to their female partners would then decide to have a baby and transmit the virus to the baby during breastfeeding, pregnancy, or at birth. And then injecting drugs practices that also is becoming very common here with young people finding it cool to start injecting heroin, which is now a very common drug here because traditionally we used to be what you call a transit country. People would just pass with heroin through a few packets here in Kenya, in Lamu, Mombasa. But now we are becoming what we call a destination. Someone brings a ship for this market, which is now something else we need to think about, injecting drugs practices. And so those are some of the ways that, and of course, we have really worked hard as a country. Progress, we just launched 10 years, and of course that's 40 years of progress, but the 10 years marked scientific advancement, they marked our really fast-track approaches, they marked public education that has been done differently because technology was evolving. And one of the things that we have seen is that we've been able to reduce significantly the number of new HIV infections. Mm-hmm. From about 100,001 in 2013, now you're about 16,500 and so. Deaths also have reduced from high as 55,000 or 50,000 plus, but to about 20,000. But mother-to-child transmission, very stubborn indicator. We just keep, and that is an indicator that tests actually what is happening in the country. Because 7.3% transmission rates from mother to child are very, very high. We are actually one of the 22 countries with the highest transmission rates. Therefore, it means that HIV is still within the general population, because for someone to get pregnant, there was a man, there was a woman, and then the baby gets infected. So that's where we are, and science has come. So we have a number of prevention initiatives that have been in the last couple of years, and one is using ARV-based prevention. And antiretroviral-based prevention works in a number of ways. One, we have the one that works with people living with HIV. It works for yourself to have the viral load in the body of the person living with HIV to be reduced significantly within the fluids, because the virus is within a number of fluids, from the blood to what is inside your bones to, all the fluids that are in the body. It reduces significantly that during sexual action, the fluids don't have the actual virus. So you reduce infection by almost 96% if someone who is living with HIV is viral suppressed and they have been taking their treatment. Because the game of this, and this is the ARV, an example, the game of this is that it circulates in the body and keep the virus at bay. Then we have moved on and realized that actually we can also, because when someone is infected, especially in the window period, most people don't know. These are diseases stay for 10 years. Sometimes even without knowing. Maybe during infection, you get a bit of a throat thing, you get a bit of flu, and then after some time, it just goes, it just stays somewhere in your body. And for some people, it can stay for up to 10 years, depending on your body. So because of that, then there's science about the negative person. How then do they take care of themselves? And that is why the ARV-based prevention, what now we call pre-exposure prophylaxis, and another called post-exposure prophylaxis, came in handy. And that's, I think, is a subject that we really want to focus on today.
Okay, so even as we look at that, and I'm just interested because you talked about significant reductions in some of the numbers that we've seen over years. So we look at new infections having reduced, deaths having reduced, mother to child, like you said, the stubborn one. Now, can these reductions, even as we now get into what PrEP and what PEP is, PrEP being the pre-exposure prophylaxis, PEP being post-exposure prophylaxis, what exactly are those now when we talk about ARVs? What are they?
So, so we have an ARV. This is a drug that combines 3 ingredients, active ingredients, and that is the one we use for treatment. So the same concept is applied for pre-exposure prophylaxis. I mean, for post-exposure prophylaxis, not pre. These ones contain almost, but the challenge is that this one only has 2 ingredients and this one has 3. So for people in long-term treatment, the ingredients combined are 3, and 2 of them are here. Now, for pre-exposure prophylaxis, it has a different set of medication, and therefore, when we give you pre-exposure prophylaxis, we don't want it to be misused, first of all, because they are all prescription drugs. You have to come to a facility. You have to talk to a health provider. And that is why we say that when you come in for the negative person, the first is you test for HIV. We confirm you're negative. Our algorithm that we developed through the National STI and Control Program, we have approved a number of test kits, and one of them that we have approved is the self-test kit that uses both, the upper gum fluids, which sometimes people call saliva-based, but it's basically scooping up here, and then also blood. So we have those 2 test kits, and then in addition to the other tests that we use in the laboratory. So that is one, to have the person negative, know they're negative. Secondly, when we give you a preventive drug, we also want to monitor you. So first, you come after we check, because there are a number of things we need to check. One of them is that if you go to the pre-exposure prophylaxis, we try and see if there's any other precondition that would interact with this. And one of them is viral hepatitis C and B. Why? Because there's an ingredient here that we always check how it affects your liver and your kidney. So people who have those challenges, they talk to the provider and then they're able to guide them on how to use a PrEP. The other thing sometimes is people with low bone density. Again, the provider will be able to evaluate that. And that's the essence of why pre-exposure prophylaxis is a prescription drug.
Okay.
And then being able to test you the first month and again the third every 3 months as you take the drug to monitor. Yeah.
Just from the name itself, pre-exposure, one would imagine then that it's like an anti-malarial. That if you know you're going to, malaria, a heavy site or area, that you take it just in case, right? So it sounds like that, Daktari.
Yes.
That, if you know you're going to be in a situation whereby there will be risky sexual behavior, then that you would take that. And so therein lies the danger. And all of this spawns from a conversation that we had yesterday. And it was in the news about a gentleman who has 4 daughters between the ages of 12 and 25. And he did see a situation whereby it would be risky sexually for his daughters because of the county that he lives in, whereby they talk about abstinence, they talk about condom use, but still, the county still keeps getting high numbers of infections every year. So Dad said, with all of this, I'm not going to allow my daughters be at risk without protecting them. So they went to the level 5 hospital and they were tested. And then he asked for PrEP because he has heard of this and said, this will be the way to protect my daughters. Is that misuse of this drug?
I think first of all, for every ARV-based drug, it should be taken through what you call informed consent. And I think this father cares about his children, but also there is the young women who also should be taken through the information and accept to take the drug. So PrEP actually reduces sexual transmission by about 99% and drug use by about 74%. But 2 things, it's not a magic bullet. It is used as part of a combination prevention. So number 1 is that in addition to HIV, we have quite a number of other sexually transmitted infections. The one dangerous one for young women and young girls, especially, it is human papillomavirus that goes to cancer, cervical cancer, and the other one is chlamydia that also leads to infertility. So that is why we say PrEP should be used as a combination and including the use of condoms to prevent sexual transmission. PrEP also does not prevent pregnancies, mistimed pregnancies. So it's not like a magic bullet. But for this father, providing the information to his girls is right. What may not be right is where anybody is coerced to use any form of medication, because these medications require adherence. And adherence is a self-initiative. And that's one of the challenges we have with some of this medication adherence. So it's important for the health provider. And I don't know the story very well, but in this country, the health providers are trained very well. So I haven't seen, and this is the first time I'm hearing a parent asking for children, but it's important that for parents also to bring the children along. Open conversation is what we need, because today you're with your children, we worry about them, and tomorrow they're not with us. So they should be able to take a decision. I must say why we encourage PrEP though. 1, you may have a sexual partner whom is living with HIV, and right now we have so many discordant couples with us. But also you also have that partner, living with HIV, but you don't see them taking their drugs regularly. So you are at risk. Then you also know that you have multiple partners, sexual partners of unknown status. You may also be in a relationship, a normal relationship, one partner. But the problem with this partner is that you never are able to discuss sex. That person you suspect, this person is seeing this person. And this is common within our context where, this guy has had an affair. You start picking his phone, or he's picking your phone, checking who you talk to, texted to. You're at risk. So before you sort out all these things of agency about your life in this relationship, because sometimes they are children, there could be also financial violations because you don't have the money to move out. The first thing you do then is to think about yourself and say, yes, this is a relationship that is just one person. Let me move to the facility and ask for something to protect myself. Especially, I can't negotiate for condoms, because in some of these relationships, you just, marriage, for example, sometimes you don't wake up and say, hi, mister, I saw your text messages yesterday, let's use a condom. Then in some cases where the women especially have experienced violence, they don't say that. So we ask you, just come first, cover yourself. It is a period at risk. Just get tested. If you're negative during this risk period, as you sort out this mess, then you're protected. The other people is people who keep having STIs, sexually transmitted infection today, and there are many. Today, they rushed into a pharmacy. They have a green discharge, especially for women, because for men, the STIs manifest early, or sometimes they don't even have any symptoms. So for women, most of these symptoms come a bit later, but you still start seeing them frequent in your life. Then again, you're a candidate that should actually seek for PrEP. Then the other people are the people who are injecting drugs, or people even who use alcohol so much that they forget to use condoms. And then you have also another group of people, for some reason, who keep coming to the facility and talking about condom bust and asking for post-exposure prophylaxis. If we see you coming often for post-exposure prophylaxis, that you had a condom bust last night, another week later you had another condom bust, then we ask you to move away from post-exposure prophylaxis, because we don't want you to continue abusing a certain drug. And I'll tell you why. Because these drugs, as I showed you here, these bottles, they all have different ingredients. And when you abuse one, you get yourself, if you get positive, it becomes very difficult to reduce the virus in your body. So we encourage those group of people. Adolescents and young women, the story of the man, back to him. Why is this parent concerned? Maybe the parent is concerned because the approach may be, of course, not ethical of what he's trying to do, but he's concerned because he's living in a place where there is HIV prevalence. Yeah. He's trying to say that, look, I can see you're sexually active. I can see your boyfriends around. I can see all of you having sex. So I think, as a parent, there's sex happening because probably of what he can see around. And for those girls who are telling us multiple partners, and let me tell you, seriously, our generation probably doesn't know some of these things. Recently when I was talking to young people, there's big issues of SAM. SAM meaning SOME. So threesome, foursome, group SAMs. All these SAMs are things that were not there for us. But what these young people don't know is that sometimes when they watch these videos, some of those people are probably on protection. Yeah. But when they try to replicate what they watch into their lives here without looking at the conditions, maybe all those people are negative. Maybe all those people are screened of STIs. Maybe all those people they are watching in those videos they access illegally are actually using condoms. Yep. But then they come here and practice it differently. I have seen girls coming to me and saying, we had threesome and one of us was positive. So there are things that are coming up, and the father is worried because of some of these challenges that are coming up that are not our generation. And then finally is about the friendship, the peer. What do the peers tell each other? Before I came in, I had to interview my daughter to tell me exactly what's the vibe. What's the vibe about PrEP and PEP? And I'll tell you that.
Having a conversation about use and just getting to understand the various methods of treatment and also prevention and for HIV, PrEP, PEP, ARV use. Dr. Ruth Laibon Masha is the CEO of the National Syndemic Diseases Control Council. She's here, she's our guest. And you've told us about, PrEP and the people who are candidates for PrEP. But then all of them must go through this whole process. You go to a health practitioner who will, first of all, do a testing for PrEP. And then there's very many other considerations that happen. That's that's introducing very many barriers to access to this thing.
So I think let's just look at the products we have, the pre-exposure prophylaxis. And in the ARV-based prevention, these products really are developed through cohorts of people. We are excited. We got oral PrEP. We are excited now. We have an injectable one that is currently approved globally. Even here, it's been approved by the Poison and Pharmacy Board. We are just waiting for a pilot to just have the injectable one, which is really exciting because you only have the injection spacing every 2 months after the first month, and you really can be able to stay having preventive ARVs in your body. We are also excited over the studies that also have shown adapivir vaginal ring, exciting for women, which you can put and remove it every month. And, it's a barrier. It's really exciting that these products are here. And we are looking forward to having them in the public health facilities as soon as our own pilot is done. But they are approved elsewhere. And then something coming up soon, hopefully very effective, is what you're calling dual prevention pill, that you have pre-exposure prophylaxis and have a contraception in it. So those are things that are coming up and very, very exciting. Now, you asked me about why then do we have people tested, asking them to come to the facility, asking them to monitor. Is because these drugs, as you know, for a long time we didn't have ARVs, people were dying. But as they are being developed, sometimes we know that the virus, the way it is, it requires active, drug to really make sure that it's attacked or it stops attaching itself into your cell. So monitoring some of those things that come with the drugs is very, very important. And not for everyone, but for the fasting, that's why we say you must really adhere to the way we have given the guidelines, is that if you're negative, if you're positive, and you're taking pre-exposure prophylaxis, what it means is that you are taking what you call suboptimal ARV in your body. And if the virus is still there, because the ARVs that you're taking are not meant to really deal with the virus the way it is already attached, then you get what we call resistance. But resistance also brings us another problem, which takes us now from the first line of drugs we use, like this one, to think of another drug that then you begin to have challenges with your own treatment program. So that is why we don't encourage the non-prescription of PrEP and PEP.
Okay. Test kits are available at pharmacies.
Yes.
So can you say that if you go to a pharmacy and you buy a test kit and you test, and you can also, so you can buy a test kit and say, let me buy the test kit and the PrEP. So we go with a partner. If we find that we are negative, then we get into PrEP.
Yeah, you can do that. The rapid test kit that is within our pharmacy, it's also part of the algorithm we have, and it is approved. However, if you test positive, that's the catch is you have to come back to the facility. Don't take the PrEP. Yes, and then you have to come back to the facility for what you say now, take you now to what you call confirmatory tests. But for the negative one, yes, we allow you to buy or be prescribed within those pharmacies. Okay. You can take the PrEP.
Does the pharmacist write the prescription? Take one twice a day with meals before. How do you take PrEP?
So
is it a one-off? Is it a daily thing?
So the oral PrEP, because that is what we have, the Truvada drug, what we have is that we encourage people to take 7 days before the planned event.
You're in a relationship, Dr. Masha. You just talked about it here.
Yes. Then
so in a relationship,
continue 7 days.
Some of those is to allow, especially for women, is to allow the drug to be within your body because these drugs depends on adherence. But then we have what you call event-driven PrEP. And this was shown to be effective with studies done, especially with men who have sex with men. And Truvada is one of the drugs that is used for event-driven PrEP. And this one is where 2 hours to 24 hours, someone start taking 2 pills, and then after 24 hours they take 1, and then after another 24 hours they take 1. So 2 1-on-1, meaning after 48 hours they're still taking. However, for women, it's encouraged to continue also using the PrEP, because these studies for event-driven, actually the results were found, especially among men who have sex with men. What happens with these drugs, it's important for them to be tested with all subpopulation. So the event-driven or demand-driven is what some of the young people have adopted. And what you know for sure, it's that it has been working well for groups of subpopulation like men who have sex with men. And I know the World Health Organization is also trying to review more data to see how it works for, the women. But for now, we encourage, especially women, because this has not been studied within our subpopulation yet to fully tell us the prevention aspect, that we continue having the 7 days and also taking the PrEP until when you risk. It's a risk-based. It's not a lifelong treatment. You can be in a relationship. Then tomorrow you leave this guy or you leave this woman who you thought you are at risk. You don't continue. You maybe go to the service provider. They'll tell you, take it until a certain period. That's also another thing. You just don't discontinue. Because you need to know, I had this last high-risk sexual behavior on this day. So how long should I stay taking this PrEP to make sure that by the time I leave out the drug, I am actually having the protection? So you don't stop at the last day you decided I've walked out of this relationship.
It's not a one-off pill, like, you take before sex and that's it.
No.
It's actually just a combination of days that you'll take.
Yes.
And you're saying how many hours before? For this event-driven?
For the event-driven,
yes.
What you've seen working for men who have sex with men especially is 2 hours to 24 hours before sex.
Okay.
And then after that, they take 2 pills, and then after that, about 24 hours later, not about exactly 24 hours. Let me not use the word about. They take 1, and then another 24 hours, they take 1.
Okay.
And it's encouraged at least thereafter 1. If the risk behavior is still continuing. But for women, it's really important that for now we continue with the 7 days and also regular PrEP until the risk comes out, because we need to see how it works for both populations. Remember, this ARV is also dependent on our blood-assigned hormones, female and male. So it's important that the studies are done for all of us to see the effectiveness in all subpopulations. The one thing I must mention is it's safe for pregnant and lactating women. It's also safe for adolescents, especially if they have well-built and their weight is 30 kilograms and above. So it's okay for them to take.
Dr. What exactly is prescription medicine?
Prescription medicine is where you don't buy the drug over the counter. So that the over the counter is where you go and say, okay, I need a Panadol. But prescription drug is where you actually need to speak to someone. Even if you get this drug online in a pharmacy, like Madawa just had a program for PrEP, they actually have someone to talk to you. So that is a prescription drug where you require an intervention of another person. You also require monitoring by a health provider. So that is why they're called prescription drugs. And then you don't misuse them.
So it has to be prescribed in order for you to actually have it.
Yes.
So now, the subject matter that we have today, pre and post exposure, are they prescription drugs?
Yes, they are.
Both?
Both.
So essentially, even if you go to a pharmacy and you test negative, who is going to prescribe it for you at that point?
So if a pharmacy is offering PrEP, remember right now we have a national program. The guidelines are the same, The algorithm is the same. So if a pharmacy is offering PrEP, they have to follow, it's a clinical site. They have someone in there who provides all the information, who provides tell you where you go for monitoring. They'll tell you where you go for checking if you have viral hepatitis, so that you don't take the drug, and you have a liver problem or a kidney problem or very low bone density. So they'll tell you where to get monitored. We have a national program, well regulated, and it's actually supposed to monitor you. It's for your own benefit.
So even if you test negative, it's not a guarantee that you test negative and you immediately buy the drug.
You will have an assessment done.
Walk us through this assessment. What exactly gets done?
So the first thing we said is to check your status.
Who does this? Is it the pharmacist, or do you have a clinician within the pharmacy who does this?
There must be a clinician offering that service within the pharmacy.
Yes.
So once you test negative and you decide you want, they take you through the PrEP, and you decide you want to get the PrEP, then they will assess first the history, just the way the person accesses. Do you have history of this? Do you have, maybe if your history of, for example, injecting drug practices, we know for sure one of the risks is viral hepatitis. So we also would want to really check for this person based on the history they've given, do they have? It's an assessment. It's based on your behavior. And then the other thing, the reason why it's good to go to the facility is that also there's the need for risk reduction. Because remember, PrEP is not a magic bullet. It needs to be used with other interventions. So, for example, if you come and say, I am just planning to keep having high-risk behaviors, it's important to be told, look, it's not...
Stop having
stop.
high-risk behaviors.
Yes. Stop. If you can't stop. So we don't want to say that it's something you tell you, okay, just go. It's like a speed governor. Just make sure that also these are the behaviors. And that's why the counseling is important.
So you will go through this entire process. That is when you'll be able to actually purchase the drug.
Yes.
So you actually can't buy a pre-exposure prophylaxis drug the way you buy Panadol.
No, you can't.
Okay, so because we still have to go back to this risky behavior that is in societies and communities today, whereby there are folks who are sharing their PrEP. So the first person to have gotten it, we assume, did so in the proper conventional way.
Yes.
That they went, they got tested, and they did all this.
Yes.
However, it's being shared amongst peers. Well, you can I have 2 of your? Yeah, sure, go ahead, because this might happen on Friday night. That's exactly.
I'll top up when you go
I'll
back.
top up when I go get my other one for you.
Yeah.
Patient 0 got it the right way.
Yes.
Isn't it?
Yes.
But then they're sharing with 6 or 7 other people with these sums that you're talking about. 3 sums, 4 sums, 5 sums. I mean, it's abhorrent, but it's happening. And I think you have to grasp that reality. Yeah. So what's the danger in that?
I think the first danger is what we just described. That I have a friend, and I want to tell the young people who are listening to me today, if you care so much about your friend, my best friend is called Nancy. Let me use her as an example. I share with Nancy, Chelule, everything. So if Nancy comes to me today, I need to do the best for her. If I went to the facility and I was taken through all these processes, I was asked about my kidney, my liver, it's important for Nancy to also get the same. Now, the sharing comes in because of the impromptuness that the sex happens and the partying happen. And what we also must do from our side is to maybe improve how we quickly can offer this service. And we have a NASCOP runs a 24-hour line that you can call. So we want to see how do we get to their space. Because we must get there also. It's an event. They want to have sex, and if they have decided. So instead of them sharing the medication, can they refer the friend to a place that they can quickly be given the service and get the assessment you're speaking about. But then let me also say that the danger of sharing PrEP is that the one person who is sharing sometimes also misses the full dose.
Their own dosage,
to also protect themselves. So you have a number of 5 people who have shared a drug, and each one of them is having suboptimal protection. So they're reducing from 99% to about 30% for each one of them. So it's important that they understand. Then the other one is that the myth that I will take PrEP in the morning and then it's like treating it like a morning after pill. It's wrong. It's actually the misuse of the drug. And that's part of why we have to provide the information and the education that the young people, we are telling them this event-driven, our PrEP on demand is a good thing, and also really looking forward to the injectable form. Because once you have the injectable one, at least now we can have people having it for a longer period, and then of course the ring, as soon as it hits the market, we know that women, especially those who are not empowered, can have the ring.
Can have access to this. Is there an app where these young people can go to?
Is there?
Like quickly, an app or a platform where so there's this information that just you're in at a party and all, and then you get into it and you answer a couple of questions. So it's taking you through that knowledge, so that then you get access to PrEP, because you're saying you want to make it as easy as possible for the young people to be able to access it. Is there a place I can go to? Is there an X handle that I can go into DMs and there's somebody active on the other side where I just go and ask, okay, so how do I use PrEP? And they tell you, so if you are going to have sex within the next 3 hours, take now, and then the next 40 days, like what you said, 24 hours later, this, and the other.
Yes. So we have a number of institutions that are running hotline. One of them is NASCOP, and then you also have LFCT Health. So I'll quickly just give you the numbers that we use.
So you've gone into these institutions, then you'll be able to get, right? You'll be able to call
Yes.
and speak to someone.
Yes.
How about one that just speaks anonymously?
The beauty about all the call centers that are available for in the HIV space, including the Madawa one that was online, is confidential.
It's all confidential.
No one is going to share information, and no one is going to say you call. And in fact, at that point, your name is not even necessary. It's actually giving you the service becomes number one driver. So I will let you know where to go and how to access. And then even you have the self-test kits. Behind the self-test kit, there's also actually a number you call. You don't just test yourself and you lock yourself in the room. So you have the number that you call, and then the person behind that call will take you through every single test, step of the test. Once then you get your positive, because the most people worry a lot are those who get the positive results. Again, they will have entire communication with you. You're not going to be paying for that call.
Yeah.
And they will finish with you and give you a referral center where they'll ask you where you live. And based on where we live, currently we have more than 3,000 primary healthcare facilities across the country. Doesn't mean you're an urban or rural area that actually you can get your ARVs from. So you'll be guided to the nearest one that is near you. You'll go there. And if possible, and where you have also an issue and you want to speak to another person, maybe person living with HIV, to tell you, especially when you've tested positive, they'll guide you the nearest support group that is available and show you how you can probably access someone to talk to. For pregnant women, we have people we call mentor mothers, and that's actually usually one of the best strategy that has been put, because again, you find a young girl who walks into the facility, or in the morning she tests herself pregnant and she finds she's pregnant, and it's unintended, so the first shock is a pregnancy.
Yeah.
The same day or maybe a day later, she tests and then she gets positive status for HIV. So again, positive. So she begins to panic, and one of the things we do is to look for a mentor mother. This is a woman who is pregnant, has been pregnant also before with HIV, and have gone through the same services. So we have all these connected support groups across the country, and that's why we are working together to reduce stigma. And as we give the numbers, the one thing that we must say is that the conversation about PrEP, including the coming up of vaginal rings and these other new technologies, it's actually about stigma. The reason people are sharing the drug is because you're telling me the story, but the reason you're not going to tell the story to the provider is because you fear stigma.
Yep.
You also fear that they know you.
Yep.
One of the things is that people must be really shocked. The health providers actually, if they meet you on the street and you're their client, they don't even remember that. Once you leave that room, they forget because they're seeing so many other people. So sometimes that self-stigma is our biggest challenge. And then that self-stigma is now with us. If you're negative today, you know this disease is like this. So when you're tested, you carry the same ideology with you into the positive status and say, now, the way I used to think about those people is what they're thinking about me. So now what you're trying to do with the negative population is that when you see yourself taking an ARV-based prevention, and then there's someone taking an ARV for treatment, you begin to see this disease differently.
Okay.
You need to know it is for all of us, those at risk and those already who have acquired the infection.
Before you give those questions, I have to ask, and it may seem controversial, but doesn't the use of PEP and PrEP then encourage risky sexual behavior?
So the studies we have had is that, of course, the way you have just discussed the challenges of even carrying these drugs, we haven't seen any cohort where we see the risk behavior has been encouraged. And let me say, one of the game changer for post-exposure prophylaxis, for example, was sexual violations, sexual violence. And the challenge we currently have with the post-exposure prophylaxis is actually to get people who are sexually violated. It doesn't matter even if it's your husband, to come within 72 hours. Because the post-exposure prophylaxis is really effective within the 72 hours before exposure. And if you follow a cohort, sometimes you find that if you don't come early, we end up with the pregnancy. And if you have a cohort of about 8,000, you find about another 100 people who got infected plus as a result of the rape incident. So that was a game changer for us. But also don't forget that we also have other ways that people get exposed to HIV. We have medics also Sometimes you're doing a procedure and even the person is positive and you end up getting the fluid into yourself through the injection that you're trying to use as an accident. Again, all those people are given the post-exposure prophylaxis. The thing about the post-exposure prophylaxis, it is not like PrEP. You must complete the dose, the 28 days. You don't, discontinue the drug. It's sometimes very discomfort. You get sometimes nausea, you feel the diarrhea,
days.
and actually even for PrEP, but it reduces with time. Stomach cramps and the mouth continue to taste funny. So they're not just drugs that you think that people they have to really think about it. But however, something like PrEP, after the first few days, the symptoms begin to go away and you get used to
So your second dosage will be much better than the first?
By the third dose, it's much
But
better.
Dr. Does it therefore not mean that that whole chain of people who provide the service, the pharmacist, the clinician and other health providers, that they actually must be trained in HIV care and treatment?
Yes.
So these pharmacies where you can get these drugs, are they specific pharmacies where you know that the pharmacists have a specific understanding of these drugs, or are they just like, let me use Panadol again, everywhere like Panadol?
No. All the facilities that are approved to issue PrEP have to also have the requirements. They have to have that provider who is trained on HIV care and management. They also have to have someone trained up on the PrEP and the use and the steps that the national guidelines have put in place. So we just don't wake up and say every pharmacy will have but we are going there. We want to have a place where we make these drugs accessible to everyone within their place.
Yes.
And that is where we are going. And especially in our journey towards self-reliance. I must say now we are offering all these drugs for free in public facilities, but they're not for free where they're bought. So we are looking at, someone is paying for them. American people, Global Fund for HIV, TB and Malaria, they are the ones giving us these funds right now with about ourselves contributing to about 20% of the same. So it actually takes about 25 to 27 to 30 billion Kenya shillings every year to acquire all these products for HIV treatment and management in Kenya alone.
Does that include
City?
time?
The end. Thank you very much for that question. Dr. Ruth Laibon Masha has been our guest. She is the CEO of the National Syndemic Disease Control Council.
This is the Situation Room, the only way to start your day.